Hello, I am Chris Ivy, and I would like to thank you for listening to my presentation of the project Opioid Reduction or Elimination with the Utilization of Transversus Abdominis Plane Blocks in Gynecological Surgeries. I would also like to make a special thank you to my faculty advisor, Dr. Sarah Davidson. I would like to start by giving a little background as to why I chose this topic. As a CRNA, we have a fundamental role in helping prevent pain, or at least decreasing it when possible. This has become an increasing challenge with the opioid epidemic our world now faces. Opioid abuse has become more concerning for providers in recent years. Providers have had to rethink and evaluate their opioid use for their patients. In 2017, there were more than 72,000 overdose deaths in the United States. I feel an often overlooked or underutilized area of anesthesia is that of regional anesthesia. With abdominal surgeries, one particular block has come to the forefront due to its ease of learning and efficacy. That is the transversus abdominis plane block, or TAP block for short. The research problem is, does the addition of the transverse abdominis block to gynecological surgical patients' anesthetic plan decrease or eliminate the opioid need postoperatively during the first 24 hours? This is also my PICO question. Uh, The purpose of this retrospective study was to evaluate the efficacy of the TAP block in women undergoing gynecological surgery and the decreased or eliminated opioid need. The primary aim of this project is to demonstrate via pain scales how well the regional block, the TAP block, decrease the need for opioid in these patients. It should easily be measured using standardized pain scales at various times during the patient's stay. Primary objective is to eliminate or significantly reduce the need for opioids during the first 24 hours. This project is a non-experimental retrospective comparative analysis to determine or evaluate the efficacy of the transverse abdominis plane block and elimination or decrease usage of opioids within the first 24 hours following gynecologic surgery. Gynecological surgery patient records in 2018 and 2019 were reviewed to verify the utilization of the TAP block or not, also pain scores in the recovery room, and during the first 24 hours post-surgery were included. Demographic variables such as age, race were examined to describe this population. As previously mentioned, the methodology for this project is a retrospective comparative analysis. It is a quantitative analysis. We also use chi-squared for independence testing, and we use some descriptive statistics. For the chi-squared test of independence, a significance level of 95% or a p-value less than or equal to 0.05 was used to accept or reject the null hypothesis. The results of the chi-square test were significant, suggesting that the TAP block provided and opioid need in PACU are related to each other. Descriptive statistics and chi-squared for independence was utilized for this project. In all areas, the chi-square test does suggest that TAP blocks provided some degree of pain relief. By incorporating regional anesthesia into the plan of care of our patients, we are able to not only decrease opioid consumption, but in some cases eliminate the need altogether. This project, although small in number, does show promise that the hypothesis of the TAP block administration does, in fact, reduce opioid need for gynecologic patients during their first 24 hours postoperatively. The results of this project did show promise of being a good adjunct to the gynecological surgery patient's plan of care. There was correlation of having the TAP block and reduced opioid need in PACU and during the first 24 hours. This can potentially lead to decreased hospital stays, increased compliance, and increased overall satisfaction of the patient. Further reviews or studies would need to be made to establish correlations to the TAP block in these potentials. Value findings are important not only to the patient, but to that of the providers and the healthcare institutions themselves. Outcome findings are paramount that we review existing plans of care and look to see if any modifications are needed. Sustainability should be easily attained until better adjuncts are created. The entire premise of decreased opioid use, increased compliance, and satisfaction of the patient makes the project a win-win for all involved.